here with Michael Fox, who's a medical doctor and a fertility specialist from Florida and an expert in helping couples get children, right?
Yes, very much so.
And you're on the low-carb cruise. How does fertility and low-carb have anything in common?
Very much so. About 8 years ago, we decided that nutrition played a huge role in fertility, and we started applying that principle to our patients, and we've had huge success.
So, how did you become interested in this whole field of nutrition and fertility? Could you just tell a little bit of the backstory?
Well, it became apparent in the late 90s that insulin was very important in ovulation disorders, insulin elevations, that is. And so just using some simple physiologic principles, it was made sense that to get rid of the insulin, which would help the ovulation problem, that we had to take the carbohydrates away. So we began to look into the available low-carb programs at the time. The South Beach diet was one that we started with, which actually did not work very well for our patients, but we had some successes, and we were able to learn from the patients their individual stories, which things worked, which things didn't work, and gradually over the last 8 years or so we've refined the process both medically and scientifically, and really trying psychologically to help patients make this transition.
So if someone's watching and they have a different time getting pregnant, what should they do?
Well, the first thing that we do when patients come in, if they have any evidence of what would be termed in our world polycystic ovary, or in maybe your family practice internal medicine world metabolic syndrome, we start with nutrition. We also add in some medicines like Metformin. And one of the most common questions that we get is, the patient says, well, doctor, if I make all these nutritional changes, do I have to take fertility drugs? Because there's some negative implications to patients about fertility medicine. That's a very common question. And actually our answer is that even in the best world, if you do nutrition in the most perfect way, we still probably don't correct everything. And so the fertility medicines which we use actually fill in that little gap of improvement.
Mm-hmm, mm-hmm. When you talked about Polycystic Ovary Syndrome and Metabolic Syndrome, how would someone know that they are in the risk zone of having that problem, and perhaps that problem could be the reason why they don't get pregnant?
Well, the polycystic ovary has a very simplistic diagnostic criteria. The most common thing that we see is cycles that are longer than 28 days. That combined with evidence of elevated male hormones, which would be facial hair growth, acne, oily skin, some people lose scalp hair. Those are sort of the hallmark changes. But anybody who has significant obesity or overweight probably has some components of this process.
And what's the first step? Is that something having to do with nutrition and carb restriction?
We're, as you know, very dogmatic about our approach with nutrition, and we push patients to get as close to zero carbs as they can. We feel like that's probably the purest metabolic state. And in general, once a patient gets to us, they've wanted to be pregnant maybe for several years. So they really don't want us to say, okay, well, now we're going to take 6 months and work on metabolism before we try for pregnancy. So for us to get the biggest bang for our buck, we push people to low carb. And as I learned in my interactions with you and other Swedish people here in the low carb world, that the high fat is actually almost equally as important, but very difficult to transmit to patients.
So why is it important to eat a high proportion of fat in the diet?
Well, one thing we found is as we talk to patients about low carb in America, because I guess a lot of the traditional low carb was in the weightlifting world and the sports world, people would go away with what we talked to them about, and they would come back really with a high protein diet,
Right.
very high protein diet. And since there's evidence that there are some negatives to that, as well as some insulin stimulation with protein, we found that that was not working as well for patients, and then they don't really like it either because all they're eating is meat and vegetables. So when you add the fat in, it seems to really balance things out, and fat seems to provide satiety. It provides a longer fuel source, in a sense.
So when you say add some fat to the diet, what does that mean in practice? What should they eat?
We're telling patients that they should eat things like real butter, heavy whipping cream, cheese, red meat, pork, mayonnaise, and then some maybe olive oil and peanut oil and things like that.
So isn't that dangerous for their hearts?
Well, that's certainly the question we get from every patient. It's sort of at the end of my talk with them, the shy question that comes out at the end is, am I going to die from a heart attack? And actually, as you know very well, all the scientific data shows exactly the opposite. It's like more fat that you eat, the healthier you are and the less risk of heart disease.
And so the metabolic risk factors improve, like blood pressure, blood sugar, cholesterol profile, and weight.
Right, very much so. And we see that in our patients.
So they lose weight.
A lot of
on
weight.
this kind of diet. And what are the results when it comes to pregnancy rates?
Our experience is, I would say it in a couple of ways. Our overall feeling is it probably doubles, maybe a little bit more than doubles the pregnancy rate.
Well, that's fantastic, right?
It's amazing. We used to struggle with Clomid as an oral drug without any nutritional intervention. And we would struggle for months and months, and we may or may not ultimately get a pregnancy, and a lot of patients had to move on to in vitro fertilization, which is expensive and has more risk. And now what we find is it's rare that patients need that aggressive therapy. In fact, the patients that really stick to the nutritional program usually are pregnant in 1 or 2 cycles with just simple oral drugs.
1 or 2 cycles, that means like in a month or 2, right?
Right.
That's very quickly. And they've been trying to conceive for
Years, many
perhaps.
of them.
So that's very impressive. I went to your clinic a couple of years ago, and I saw you had a whole wall full of pictures of babies. So how many of those babies are low-carb babies, low-carb pregnancies, would you say?
Well, at this point, many, probably approaching thousands.
Wow.
So,
yeah. So do you see any risk associated with this? I mean, some people wonder, can you really eat a low-carb diet and get pregnant? Could that perhaps somehow be dangerous for the fetus, for the baby?
we don't think so. I saw an interesting quote that somebody had to answer that very question, at least about nutrition and pregnancy. And the quote was basically that, for millions and millions of years, humans ate virtually no carbohydrates, and we survived as a species. So that's pretty good evidence that there's probably no harm to the pregnancy.
But we were eating like fruit and vegetables, maybe nuts and berries, and so some carbohydrates we must have been eating for millions of years, right?
Oh, that's correct. I would say probably some vegetables and few fruits, and certainly compared to our fruit environment today. So, but even patients that really push to try to get to 0 carbohydrates are still getting probably 15 or 20 grams of carbs a day in their fruits, and then we promote nuts as well that have some carbs.
And you ask them to eat like meat, full fat meat and fish and eggs and butter and all that stuff.
All that good stuff.
All that good stuff. So what do the patients feel about it? Do they think it's good stuff?
Many do. Many have that initial response that they've been denied that all their life, and they really enjoy the possibility of eating it again. Others really struggle to get rid of their sweets and their carbohydrates, breads and pastas and things like that. So
it's a bit different how easy or hard they find this nutrition thing, right? So you said that it's okay to eat, probably, as far as you know, eat a low-carb diet during pregnancy. What about after birth, when breastfeeding? Can you eat a low-carb diet, or does that have any negative implication for the breast milk, you think?
I think probably the opposite. Breast milk is a high-fat fluid, and so a high-fat diet would make a lot more sense for that.
But there's a lot of sugar in the breast milk too, right? Lactose.
That's true, but your body can create that out of fats and proteins. So,
have you heard of any problems from women doing low carb during pregnancy, breastfeeding, so on?
No, in fact, actually we find the opposite. We find, at least in we follow patients for the first 10 weeks or so in our office before they go to the obstetrician, but very little nausea, very little cravings. And then when we see people back for baby number 2 and we are reviewing how they did in the pregnancy, very low to modest weight gain, which is what we would say maybe 15 to 20 pounds in a singleton pregnancy. And we've even had interactions with healthcare workers that ask us what to do when they start having their blood pressure go up in pregnancy and start having some protein in the urine. And when they get on a low-carb diet, those things seem to go away. So no negative impact, but a lot of positive.
And that's interesting, because a lot of women gain much more weight, right, during pregnancy. You said, we say 15 or 20 pounds for a pregnancy.
That's what we would
weight
recommend.
Gain. That's quite a lot lower than the experience of most women today, right?
Yeah, probably the average non-affected patient would gain 25 to 30 pounds. Patients with significant insulin resistance, we see 50, 60, 80 pound weight gain, very common.
Well, that's not a good thing, right?
Not at all.
And you might get pregnancy diabetes.
Gestational diabetes
right.
is a big risk factor.
And what happens when those people go on low carb? Have you seen anybody who developed gestational diabetes go on a low carb diet?
Our problem is we're not exposed to the pregnant patient as that develops usually,
right.
Later in the second and third trimesters. I mean, certainly they're sent to nutritionists, but it's more the traditional nutrition, like the American diabetes approach, which is a 30 to 40% carbohydrate diet. And then just from training, that's not a very positive intervention. So we'd love to see more studies in that area, and we would love to be a part of that, but it's hard because we don't see the patients at that point.
Right. You were mentioning nausea during pregnancy, also a very common problem, right, for a lot of women. What's the cause of that, do you think, and what could you do about it?
I mean, my thought about this process is that, and the analogy I use is what pregnancy does is it magnifies the insulin resistance disease, maybe twofold, threefold. So in the physiology where the insulin goes very high, which pushes the blood sugar very low, so-called hypoglycemia, in pregnancy what we see is faster and more dramatic drops in blood sugar, which create the symptoms of hypoglycemia in a much more dramatic way. And one of those symptoms is nausea, and another would be sort of craving food or carbohydrates. So the women that go on food binges, and if you think about it, it's typically carbohydrates. They want ice cream or some sweet, and that also contributes to the massive weight gain that we see in those patients.
So how, I mean, if you get that kind of problem, nausea, cravings, what can you do?
Well, hopefully you're already on a low carbohydrate diet if you're with us, but we recommend trying to cut out all the carbohydrates. But even maybe more important is trying to, number one, eat first thing when you wake up in the morning. Most people tend to wait an hour or so, and by then they're already hypoglycemic. That's why the nausea is more common in the morning. And then during the day, trying to eat at least every hour and a half to 2 hours, small snacks to keep the blood sugar up.
Like what kind of snacks, if you're going to do low carb as well?
Right. If you're a low carber, we recommend nuts, primarily peanuts, almonds, walnuts, and pecans. The no sugar peanut butter, pork rinds are a common food in the U.S., and then things like cheese and even meats or vegetables with some sort of high-fat dip. Those are good snacks.
Yeah. If morning sickness is a problem, should they put their alarm clock on and get some food during the night, or?
We've tried that for some patients that even if they get up first thing and they're already nauseated and have a problem, to wake them up in the middle of the night and eat some low carb food.
Did they have success?
It seems to work. But there are some patients that no matter what you do, they have nausea in pregnancy.
Right, yeah. So I'm curious, because this is still a bit unconventional with using low carb diets during pregnancy, breastfeeding. What kind of reactions do you get from your colleagues, other medical doctors, and people working in this field?
Well, we've been doing this now for 8 years, so we're in a fairly large metropolitan area. Our story has sort of gradually trickled out. The reaction we typically get is that after we counsel the patients very carefully and intensely, when they get to the obstetrician's office, typically they're told to eat whatever they want. You're eating for two, just don't worry about it. And I think patients, because our story is not conventional and they're now at a new doctor who's now in charge, they're going to follow that advice, and they typically do. But often they then see the reaction to that, which is what we told them would happen, which they gain a lot of weight and they may have, blood pressure problems or blood sugar problems. So second go around, when we see them for the second pregnancy, they're often a little more apt to listen and follow the advice.
More receptive to your advice. Yeah. But what do other doctors say to you? Do you get any criticism?
Well, I really don't get any.
This is you can't do this, or?
We haven't really had that sort of that degree of negative feedback. I think overall, most physicians somewhere in their subconscious realize that what we're saying is really right, but they're just not willing to kind of get into it, I guess.
Do other doctors in fertility medicine do this, or are you the only one? I'm
not the only one. Actually, Dr. Gil Wilshire is in Missouri. He's another person who's very much into the low-carb world. We 3 to 4 years ago now at the American Society of Reproductive Medicine formed the nutrition subgroup, which is there to look at nutritional science and as it relates to fertility and pregnancy. The disappointing thing is there's usually only about 10 or 15 people that show up to that particular part of the meeting, whereas there might be 200 or 300 in other subgroups. So it's in its infancy at this point.
Why is that doctors are not interested in nutrition, or what?
I don't know. I use the story of when I was in med school. Our nutrition class was 1 hour once a week for one semester.
So just about nothing, right?
Right, and it basically says to the medical student, this is not important, and other classes are much more important.
But when you compare the effectiveness of medication or nutrition for women seeking a pregnancy, what would you say about the difference in effect?
Well, I do say, because we use Metformin as part of the treatment of this very process, I say to patients, 80 to 90% of what I can do to improve this process is nutritional. and maybe 10 or 15% would be medicines and other things.
So your colleagues that aren't interested in this, they're missing out on 80 to 90% of what they could do.
So, I mean, it's the most powerful treatment I've ever been exposed to, without a shadow of a doubt.
That's fantastic. So anybody having trouble getting kids, especially if they have excess weight, irregular menstruation, long cycles, excessive facial hair growth, acne, stuff like that, what should they do?
Well, it would be great if wherever they are they could find a physician that embodies this philosophy. The one thing I would also throw in there, though, is don't forget about the guys. The guys are also often overweight, they have metabolic syndrome, and their testosterone levels are low and their sperm counts are often very low as a result. So we actually in our practice will treat and evaluate the males in a similar way.
Right, and what kind of effect do you see on their fertility and testosterone levels and so on?
We don't follow them quite as long, I guess, over time, and we generally treat them for their testosterone, so we don't see just the simple effect of nutrition. But the guys compared to the girls actually lose a lot more weight, and their metabolic parameters seem to improve a lot more quickly.
It's easier losing weight on a low-carb diet for guys.
Right, and it frustrates the females.
I can imagine. So you work in
Jacksonville, Florida.
Jacksonville, Florida, right? And you have a large clinic there with a lot of doctors and other people working there. What do they say about this? Are they joining you in this crusade, or do they,
They are. We're at the Jacksonville Center for Reproductive Medicine. There's 3 physicians and 2 nurse practitioners that work with our patients, and we're all low-carb trainers, and we teach low-carb to the patients, but we're also all doing low-carbohydrate diets ourselves, which I think is very important.
Right. So anybody interested in this kind of approach, they could seek you out in Florida. Could you go there from other places too, or?
We have a lot of patients that travel a great distance, and not necessarily for the nutritional treatment, but for various other things that we provide.
So do you have a website or somewhere people can go and check you out?
We do. It's jcrm.org.
jcrm.org. Great.
Jacksonville Center for Reproductive Medicine.
Yeah, I'll put up the link in the under this video, and so anybody can go and check you out if they're interested. Is there any other way to find fertility doctors using low carb approach? Do you know any other people in other parts of the U.S.?
I really don't know any specifics, and I'm not sure if the nutrition subgroup members are listed on the ASRM website. American Society for Reproductive Medicine. They might be. It's not a long list.
It's not a long list. Maybe it's gonna get longer.
We hope so.
So how can we spread this message so that more people can find out? I mean, I'm just a family physician, but I have people with PCOS sometimes, and I have had a few who went on a low carb diet and they got pregnant after having trouble before.
Right.
So even for me, who's not really specialized in this, I can see the effect quite clearly. You'd wish that more people would get the chance, right, to get this information and get to try it out. How can we make that happen?
I would say, fortunately, we have people like you that have taken a big web presence. As we've learned here at the meeting, I think it has to be a grassroots effort. Certainly our governments are not going to embody this, and a lot of our national medical groups are not supporting this idea at this point. So it takes patients and people, and then it takes education of physicians.
So what's the problem? Is it just that there's no money to be made in this? No good food is not profitable enough?
Well, you're asking the million-dollar question, but yeah, I think the food industry is a big impediment. I think the drug industry is a big impediment, and just, I mean, at least in the U.S., the medical establishment is designed more as a after the fact, treat the problem, and not in a preventative methodology.
But you'd think, you know, when fertility care is private, patients would want to seek out the place where they can get the best help and the best chance of getting pregnant. Aren't there like some sort of scoreboard? You know, you can see your percentage chance from different centers. Maybe if there was that kind of thing.
Well, actually, that works against us, because the scoreboard that's out there, which is sad, is for in vitro fertilization. So for people like us that are using a nutrition intervention that helps people get pregnant without IVF, there's no data collection for that. So there's no, it makes us look worse.
So there's no data for all the people getting pregnant without needing in vitro.
Right. And that's really what we need.
That's what you should have, like, you know, advertise that you have like how many of the patients seeking help from you do get pregnant without in vitro, would you say? And
for this problem?
Yeah.
If this is their only problem and they follow what we recommend, I would say 95%.
95% getting pregnant with no in vitro?
Correct. Which before
after having trouble before that. That's pretty fantastic, right?
Yeah, before we started nutrition treatment, it was about 40 or 50%.
So you went from 40 to 50% up to 95%.
That's
just using nutrition.
It's amazing.
Some medication when needed.
Right.
That's fantastic. So anybody can check out your website, and you mentioned the way to spread this kind of information using the internet. You're going to put up some instructional videos and stuff like that on your website, right?
We're working on doing all that.
So it might be up there when people watch this video. So thank you so much for sharing all this information.
Thank you, Andreas.